Hello, everybody. Welcome to the TVN webinar series, and thank you for taking time out of your busy schedules to join us today. Today's webinar is on hip fracture quality indicators, a scoping review. These are the final results of a TVN-funded knowledge synthesis grant, and it will be presented by Susan Jaglal and Kristen Pitzul from the Toronto Rehabilitation Institute, and I'll introduce them in a little while. But this is a regular forum. It's a monthly webinar where we present or share research and insights on advancement on caring for frail elderly Canadians. And over the past couple months, we've been highlighting the outcomes of TVN-funded knowledge synthesis grants, and today's presentation follows along the same lines. Just a couple of housekeeping issues. Everybody is muted during the webinar to minimize noise and allow our presenters to fully present. But we would like to answer as many of your questions as possible. So if we could ask that you submit your questions online during the webinar using the chat function. What we'll do is we'll compile the questions, we'll aggregate similar questions, and then get to them immediately following the presentation. If there's a lot of questions that we don't get to, we can post them online afterwards. But we usually get through most of the questions. In addition, today's webinar will be recorded and will be available on our website in the next couple of days. So if you miss any of it, or if you have other people that you think may be interested in it, please refer them on to the webinar.
Yeah.
So just before we start, I'd like to introduce our presenters. So our presenters are Susan Jaglal. She has a PhD in epidemiology from the University of Toronto and is currently the president of the Canadian Society for Epidemiology and Biostatistics. She's a professor and vice chair for research at the Department of Physical Therapy at the University of Toronto, and is senior scientist at the university, also a senior scientist at the University of Toronto, and her research is on osteoporosis, rehabilitation health services with emphasis on utilization, appropriateness, effectiveness of services, and knowledge transfer, things which are of high interest to TVN and likely to most of our audience. I'd also like to introduce Kristen Pitzul. She's a PhD candidate, health services research at the Institute of Health Policy Management and Evaluation at the University of Toronto. She has a Master's of Science in Physiology, Bachelor of Science in Biology from the University of Western Ontario, and her research focus is also on performance measurement, program evaluation, and knowledge synthesis, and her doctoral thesis is on the optimization of post-acute care pathways in hip fracture patients. So without further ado, I'll turn over the presentation to our presenters today, and I'd like to welcome them.
Okay, thanks, John. Yeah. Okay, can you see the slides?
Yes.
Okay, terrific. Okay, so I'd like to, as John said, I'd like to thank everybody on this for attending this webinar on this lovely summer day. First off, I'd like to recognize the team who worked on this project. Kristen is my PhD student. We also had Dr. Sarah Muntz work on this. She was my past PhD student, and her expertise is in systematic reviews. In terms of our clinical experts, we had Dr. Suzanne Morin and we had Dr. Lauren Beaupre, who are experts in hip fracture care and also looking at quality. To do the scoping review to help us with the search, we had Laurie Perrier, who's an information specialist, and again, in terms of helping with our dissemination efforts, we partnered with Bone and Joint Canada, and there I'd like to recognize Rona McGlasson. So I'll start off briefly with the epidemiology of hip fractures. As you all know, hip fractures cause significant morbidity and mortality and high healthcare utilization worldwide. We know that when a person suffers a hip fracture, these slides are advancing on their own. So we know that hip fractures cause significant morbidity and mortality. At about 1 year following a hip fracture, almost close to 20% of patients would have died, and another 25% would have been oh, could I ask that? Got none. Okay, maybe I'll just do it this way, and then there won't be the timings. So in terms of hip fracture care, we do need to optimize patients' recovery to allow them to continue to live independently in the community. Because of all of the osteoporotic fractures, the hip fracture is the most costly and deadly. So one of the things then that we're interested in is determining whether hip fracture care is optimal. And to do this, we must measure the quality of care delivery. So the purpose of this study was to synthesize the current evidence surrounding quality of care indicators for hip fracture patients, and in fact the overall approach that we took was a scoping review approach. And if you'd like to get details of the scoping review protocol, Kristen published this in BMJ Open in October of last year. In terms of the methodology that we used, we followed one of the sort of classic scoping review methodologies, and that's the one proposed by Arsky and O'Malley, and they updated this recently with input from Levac. So for this for this particular study, one of the challenges for us was actually operationalizing quality of care indicators. So we decided to go with the definition as a validated quality of care measure, and also again, given that we weren't sure what we were going to find, we wanted to be quite broad. So we also went with potential quality of care measures that have a descriptive statement. So before I get to some of the results, I just want to review briefly the framework for scoping review. So the Arsky and O'Malley, they suggest that in stage 1 you identify the research question. So here you outline the concept, the target population, the health outcomes, so that you can actually really clarify both the focus of the scoping review and then establish what you need to do for the search strategy. The second stage involves identifying relevant studies. So some of the suggestions are that you have to at the same time try to balance breadth and comprehensiveness with then feasibility, and so it's to help with that, it's actually good to have team members with both methods and content expertise, which is something that we did. Stage 3 is study selection, and for this stage, you really want this to be transparent and replicable. So one of the ways in which to achieve this is by having a number of people review pretty much everything. So at least 2 researchers should each independently review the abstracts. Again, once you're partway through the process, the reviewers should meet midpoint, and then again at the final stages to discuss any challenges. And in some cases, you might even have to go back and refine the search strategy. Then at the next stage, once you've decided on the abstracts, 2 reviewers again should review the full articles for inclusion. So in terms of stage 4, that's when you're actually doing the data abstraction. So a good process around this is to actually, again, have the research team collectively develop the data collection tool or data charting form, and once again have 2 researchers independently abstract data from a few studies, so that way you're basically pilot testing the data collection, your data charting form. And the next stage is where you're collating, summarizing, and reporting the results. And so it's basically a descriptive summary of the studies that you've looked at, and so these are some of the things that one collects in terms of how many studies, the types of study designs, etc. The other thing that we do at this stage is actually the description of the analysis, and a lot of this is actually driven by then the question, the question that you're asking. So in some cases, if it's a very you're looking at the extent of the literature on a particular topic, you might then, with what you find, you might then do some content analysis. Ours was not content analysis because, again, we were looking for specific indicators, so we were counting, charting and counting up things. To see how often they appeared. Again, if you're doing a scoping review where you're thinking of looking at where there are strengths in the literature or gaps in the literature, it's also a really good tool for helping you to summarize literature that way. And finally, the last stage, which is considered optional, is to think about once you have your results, then consulting with your stakeholders again. So again, really a knowledge translation component. Okay, so let's flip to now what we did. So our specific scoping review question was what patient, institutional, and system level indicators are currently in use or proposed for measuring quality of care across the continuum for individuals following a hip fracture. In terms of study eligibility, we decided to look at English language studies published from 2000 to 2014. We were looking at any study designs, and as our question indicated, we were targeting quality indicators that were relevant to patients, institutions, or the healthcare system. Because we're looking at hip fractures caused by a low trauma, we then we were not interested in studies that talked about fractures due to high trauma, for example, like a motor vehicle collision. We also excluded some conditions not more rare conditions not really related to underlying bone density, such as Paget's disease, and we also excluded any studies that were talking about malignancy in particular, because the type of care provided in these cases is going to be different than sort of the care provided for the more traditional hip fracture patient. In terms of the search strategy and screening, our search was conducted by Lori, and so she is an experienced information specialist, and when that search the search was created, she actually added another step where it was peer reviewed by another information specialist, and so from that we actually tweaked we tweaked her search strategy. We identified studies from a wide variety of databases: Medline, CINAHL, Embase, AgeLine, Cochrane, Pedro, and we basically we followed the Arsky and O'Malley process. In terms of level 1 screening, that's where you screen titles and abstracts, and so there we pilot tested our form with 2 team members, and we used a random sample of 50 articles, and this was helpful because it enabled us to clarify our inclusion and exclusion criteria. And then basically we assigned articles to 2 members to do the level 1 screening, which is the titles and abstracts, independently. And where there was disagreement, then those were discussed, and if we needed a third reviewer, we brought somebody else in. So then there was consensus in terms of what we were keeping. The next stage was then the full text review of potentially relevant articles. And again, all of the full texts were reviewed by 2 reviewers. In terms of data collection, like I said earlier, the abstraction form was pilot tested, and so we abstracted the following information: the study characteristics, the the indicator definitions. So where applicable, we included the numerator and denominator definitions. Because we were interested in the continuum of care, we also included where this indicator was applicable, for example, acute care or rehab or the community. If there was information on the measurement properties such as reliability or validity, we also noted that in our data abstraction. So in terms of results, this Kristen will attest, this turned out to be a very large undertaking. After the search, that yielded about 2,000 studies, and because we had then pilot tested the form, it actually helped us to refine our exclusion criteria. So we decided to exclude or throw out anything that talked about intraoperative quality indicators, any studies that were that came up, but they were clinical drug trials, anything comparing equipment, and studies with hip fracture patients who were less than 50 years of age. So that left us with 495 studies for the level 2 screening. And so from that, we then, after reading the full text, you then reapply your exclusion criteria, and so that left us with 224 studies. So now on to, and so where did most of these studies come from? The vast majority came from the UK, the US, and the Nordic countries. And again, this is not surprising because these are countries where there's a high incidence of hip fractures. So in terms of the results, the most validated quality indicators were from the acute care setting. In fact, we only had 4 validated ones that were in the post-acute care setting. So that was length of stay, indicators around mobility, gait, and muscle strength, as well as functional ability, and finally readmissions to hospital. And that was it. Whereas for the acute care phase of hip fracture recovery, you can see that there were lots of validated quality indicators that came up. So one of the challenges with this was, again, that a lot of you're pulling a lot of this from guidelines as well. So as they get updated, things get repeated. So one of our most common sources was the NICE guidelines, and and also the British Orthopedics Association. So again, one of the things with this type of work too, timing is a huge issue, where depending on sort of guidelines at the time or current practices, the indicators might change. So here's where we saw some changes. So the British Orthopedic Association had the indicator access to orthogeriatric services, sort of as more of a yes-no in 2007, but then in 2012, NICE refined this definition to be involvement of an orthogeriatrician within 72 hours of admission. The other one that that changed was surgery within 48 hours of admission. The more recent British recommendation is within 36 hours of admission. So one of the other, I guess, findings from this scoping reviews was that we found a lot of other common quality indicators, but a huge challenge with this work is the varying descriptive statements. So we had there's total length of stay in the hospital, and you could have is that from admission to discharge? Does it include, for hospitals that have a rehab unit, is it the length of stay from admission to discharge from rehab? There's some variability there. Is it in terms of mortality? There are all kinds of combinations and permutations. The most common were in-hospital mortality and 30 days post-discharge. There are also a myriad of in-hospital complications and different ways to measure functional ability. So, for example, there might be some might use the FIM index, others might use the Barthel. In terms of readmission to hospital, again, 30 days was fairly common, but there was also 1 year post-discharge. And finally, there was change in pre-morbid residence following discharge. So, for example, did the patient go into rehab or retirement home, a nursing home, following discharge? In terms of post-acute care, many of the measures of quality in the post-acute period were not validated, and you saw some of that in that earlier slides, and nor were they implemented into national guidelines. So this is clearly an area where there's some work to be done. And here, one of the biggest issues, things aren't validated, so of course then there's a lot of difference in terms of how things are measured, and something like functional ability can vary quite a bit. For example, we had recovery of activities of daily living. It could have been the results on a timed up and go test, so you have an objective measure there of functional ability versus a change in the FIM. Some even included measures of self-efficacy. So this was basically all over the map. In terms of some of the more common measures that were included for the post-acute period. A length of stay was very common in either the rehab institution or in home care. We saw measures, as indicated earlier, of functional limitations, and they varied in terms of either being some including ambulation type measures versus physiological or strength measures. A common one was return to the premorbid living situation, mortality, things like falls efficacy, and then health-related quality of life. So there are a large number of these proposed, but not really validated. So in terms of our summary of what we found, the review suggests that the current evidence doesn't provide validated quality indicators for measuring care delivery across the entire continuum, and in particular not across the post-acute setting. So in fact, we actually have to, this is one area where we have to do some future work in terms of improving the quality of care for hip fracture patients. Some work on how we measure that quality of care. So now I'm going to turn it over to Kristen to talk briefly about these indicators, and again some of the differences that we saw in some of the measures that are being widely proposed for use by health regions or health authorities. Okay, so can we switch over to Kristen? Or do you want me to do the slides?
Okay, so I think I've made the presenter now.
Kristen, we can't hear you.
Can you hear me?
Yes, I can hear you now.
Okay, great.
Do you have the slides up?
Yep, can you see them?
Yeah, perfect.
Wonderful. Okay. Hi, everyone. Thanks for joining us. So I'm just going to highlight 5 indicators that we were actually asked about from a group in Australia. So they are, as Susan said, kind of relevant across health systems. And they are time-sensitive admission measures, length of stay, mortality, patient satisfaction, and health-related quality of life. So time-sensitive admission measures included time to surgeries, so mean, median, which was either the number of days or number of hours from admission to surgery, and that was in 14 studies. And there wasn't really any discrepancies there. However, there was surgery within 24 or 48 hours, which is just defined as the percent of patients who had surgery within 24 hours of admission or 48 hours of admission. And there was some variation in the 36 studies that looked at it in terms of the starting point for measuring that indicator. And then there was kind of a variety of other time to surgery measures, such as percent of patients who had surgery within 36 hours, within 48 to 72 hours, greater than 72 hours, 6 to 10 days, or greater than 10 days. So there's a lot of kind of discrepancy in terms of what's considered a delay to surgery or early surgery and where that starting point actually is. Is it in the ED? Is it when the person admits for surgery, et cetera? My slide is not switching, so I'm just going to do what Susan did. So here we go. So time from presentation at ED to admission. Number of hours between the time the patient presents at ED with hip fracture and the time the patient was admitted. 13 studies looked at this. And 6 of them stated that the patient should be admitted within 4 hours. So kind of using that as an indicator. Geriatrician assessment within 72 hours was used in 1 study, as was time from admission to medical clearance or time from admission to pain relief. Time from surgery to rehabilitation was defined as the mean number of days from surgery to rehab ward or a separate rehab facility, and that was used in 4 studies. Time from surgery to movement, so that's the mean number of days from surgery to movement, was used in 3 studies. Movement was defined as first getting up, versus mobility, and use of a walking aid. So kind of 3 different ways of measuring movement in each of the 3 studies. So length of stay, which as we all know is used as a quality indicator in a number of different health systems. There was total institutional length of stay, some type of sub-institutional measure of length of stay. So, you know, time in acute bed, time in a rehab bed, time spent post-operatively, time spent in an orthopedic unit or an ICU, and then another type of measure of length of stay, such as excess days over the mean total institutional or deviations from expected length of stay based on some type of case mix group or whether or not a target length of stay was met. But the most common measure of length of stay was that was used was total institutional. Mortality, which is also kind of a classic indicator that's used in a number of studies. So in-hospital mortality, which was defined as the number of adults with hip fracture who died prior to hospital discharge, was used in 31 studies. 30-day mortality was used in 26 studies, but the starting time point, again, whether it was admission to hospital or like time point of post-operatively or discharge from hospital, varied between the studies. Long-term mortality, which is the number of patients who died kind of 1 year, 3 year, 4, even 5 years after fracture. The starting point, time point varied as well. And the actual definition of long-term varied, obviously, between the studies. And then there were other measures of mortality, such as the number of older adults with hip fracture who died within 3, 4, or 6 months, or the last date of study follow-up. So there's a big variation in terms of when we're actually making these measurements. Excess risk of death, which was defined as the difference in cumulative probabilities of mortality between 2 comparable groups using a proportional hazards model from 14 days to 1 year post-operatively, was used in a study from Finland. And excess risk of death using more long-term, so up to 8 years following fracture, was used in a United Kingdom 2010 audit. And survival, which was just the post-op length of survival for all patients who died within 12 months, was also used in a pragmatic RCT out of the United Kingdom. So patient satisfaction, which is kind of, was only used in 4 studies, and to me is interesting. One study from France defined it, using interview questions, so self-report, kind of pain management, or patient satisfaction with information. A Cochrane review in 2008 found defined it as adherence, basically, to a given program or intervention. And a Canadian study adapted the patient satisfaction questionnaire. And a study out of Norway used visual analog scale. So all kind of different ways of looking at the same measure. And similarly, health-related quality of life, as I'm sure many in the audience know, is measured in a variety of ways. The most common was SF12 and SF36, used at varying time points post-discharge, followed by the EQ5D, which is also administered post-operatively at various time points. and the World Health Organization Quality of Life Instrument was used in 2 studies, and combining kind of independence and quality of life was used in another study. So all to say that, in highlighting just these 5 measures, there really is quite different definitions, and at different time points they're administered. So it really is, as Susan said, quite a challenge to kind of summarize them and report them all, and even to understand, which ones we should be implementing where. So the study has several strengths and a couple of limitations. One strength is that it was a systematic scoping review methodology, including a peer-reviewed search strategy, so it was quite a rigorous approach to a scoping review. It included quality of indicators for hip fracture patients across the entire continuum of care, and not just within the acute care setting, which is where many of the indicators are kind of traditionally focused. And it included both validated and potential quality of care indicators, so really measures of outcome measures and process measures for hip fracture patients were included, which will provide insight into which potential indicators require further validation. And the limitations, we only included English language studies, and in keeping with scoping review methodology, we did not evaluate the quality of the evidence. So our team would like to thank Atiya Hamraj and Saima Hussain for their help with retrieving articles, and as well as TVN for the generous funding that we were provided. And of course, for more information, feel free to contact myself, Kristen Pitzul, or Susan Jaglal for further information, and we welcome any questions.
So Kristen, what are the next steps after publication of the scoping review?
So first we need to publish a scoping review. That's the next step. And then, I mean, I would take kind of the more novel indicators in the post-acute period and see what is actually measurable from at least an Ontario perspective or Canadian perspective, and what we have the data for.
Okay, so which indicators do you think would be the most useful for all health systems, regardless of context, to explore in the post-acute period?
I think that's a very difficult question, and to be perfectly honest, to me, context really matters. So I don't know if there is actually an answer to that question coming out of this scoping review. I think that you would have to take the indicators to your own health system and decide. I think there's interest, obviously, in more novel measures such as patient satisfaction, but depending on the data available and and the funding models in your health system, the important indicators would just vary.
Okay. Susan, do you have anything to add to that?
Okay. Oh, thank you. Yes, I think from an Ontario perspective, one of the main types of indicators that people have been interested in has actually been on something around functional improvement, and whether that also means that do you use a standardized measure like the FIM, like we do in Ontario, or is it something more generic, like what proportion of people are actually discharged home or return home? that seems to be, rather than sort of traditional measures like, for example, length of stay, which really then varies depending on the health system.
Okay. So I have another question. I'm not sure which one of you will answer this. How do you increase the quality of quality indicators for post-acute care, since the majority are directed to acute care?
Mm-hmm. Okay, I guess that's my question, Kristen.
Yeah, no, I'm happy to give it a go. I'll give it a go. I mean, increase the quality of the measures in the post-acute period. I mean, you first need the data to support the measurement of it. I mean, Susan, do you have anything else to add to that?
Yeah, I think it, you know, what this does is we basically have to start the conversation in terms of what would be seen as important quality indicators for that period, and perhaps, you know, start with a much reduced list compared to, you know, what's being used for acute care, and get agreement on that, and then work through the validation and the data collection, and to put in those processes. And I know some of that discussion in Ontario has been started through the with the work at Health Quality Ontario that they've been doing on quality-based funding. In fact, hip fracture is one of the conditions that where they've developed the clinical handbook, as well as trying to now figure out what funding model should be for hip fracture.
Okay. So either one of you can take this. How do you increase the adoption of quality indicators for hip fractures?
I guess I'll start, and I'll let Susan add to my response. So increasing the adoption of quality indicators in general. I mean, the easiest thing to do is to tie some type of funding to it, because that typically allows, or, you know, really encourages institutions to get on board with it. And I think, you know, the way that they're developed, as Susan was saying, to have the clinical panels and have the stakeholders at the table from the get-go and have them engaged in the actual formation of the indicators, I think it really helps in terms of KT.
Yeah. So to add to that, so you really, Kristen, really spoke of the you know, the importance of buy-in at the development phase. I think the other important part with adopting quality indicators is the issue of providing the information from the quality indicators back to the level of the practice, because one of the challenges I think we have with this type of work is we collect all kinds of information and we expect things to change, but then that information never goes back to the floor. For example, the orthopedic floor, it just, you know, vanishes. So people feel like they're collecting information in vain, because they never see how it can be used to change anything in which they're doing. So I think that's where we need to do much more work as well, in terms of creating a mechanism where there's a very good feedback and timely, because one of the problems with a lot of this information, especially the things that are in administrative databases. You know, it's like a year out before or more before you get you get the data, and then you summarize it, you feed it back, and you know, things could have changed, and people then feel that it's no longer relevant. So working towards a system where you can get timely information, I think, back to the providers will actually help with our adoption.
Okay. So how much did the definitions of each indicator vary between the studies?
I'll let Kristen answer that one.
Yeah, I mean, as we kind of highlighted with 5 of them, they varied a lot. The only ones that don't vary, honestly, are from NICE, like the ones that like are tied to a funding model within a health system or within numerous health systems. You know, those 6 or 7 indicators they use, like access to an orthogeriatrician, et cetera. But when it came to like between studies and literature, I mean, even mortality, which to me, as you know, a junior researcher, seemed initially to be such a cut and dry indicator. There's a lot of variation and in both the numerator and denominator. So it makes it difficult to even compare performance between systems.
Okay. Susan, do you have anything to add to that, or I'll give you one of the maybe last questions?
No, nothing. I guess we were surprised by how much variation there was across studies. And one indicator, and Kristen can comment on this one in particular, that people are interested in is this time to surgery. And so the variability in time to surgery, like is it time from, you know, when the person had the fall, when they're admitted to the ED, what if the patient is transferred from another hospital for their surgery? Do you include that time? So it became, even though it's like it's seen as a very important quality indicator to measure, the variability in how it was being measured, I think, was quite astounding. Anything to add to that, Kristen?
Yeah, so time to surgery, and because, as you mentioned, kind of functional ability being the more post-acute way or focus that or indicator we should focus on, I think the variability and the way that functional ability, or just the concept of morbidity, is measured is astronomical, and is a significant concern when it comes to using that as a quality indicator in the post-acute period.
Okay, thanks. Okay, I have one last question. For elderly persons with other serious disabilities and illnesses, there's an initial question of whether to repair the fracture and what supportive services should be available for those for whom the decision is not to repair it surgically. Did you see anyone even beginning to approach this set of issues?
Okay, so I'll start and I'll let Susan add. So not repairing the fracture because of a complex patient. It didn't dominate our studies by any means. Most patient populations were made up of those that were undergoing hip fracture repair, so they're actually having surgery. So yeah, I didn't really see much in terms of a quality of care measure for how to handle those more complex patients, not undergoing repair. And they weren't. It maybe that has to do with our search strategy, because that kind of patient group is a different group than what we were after. More the fragility fractures that that are where the hip fracture is the dominant condition, so not that kind of multi-morbid complex patient. Susan?
Yeah, I'm trying to recall. I don't think we in our search strategy, like we made that distinction with surgically treated and non-surgically treated, and in fact, Kristen, I'm just trying to recall. Remember, we were having this discussion at your thesis committee meeting about what proportion are non-surgically treated, and it's really quite small.
Yeah,
but
in Ontario, it's about 5% of the
okay.
population. So, yeah, it's quite small, and I don't think we excluded, but just our other search terms and that were used. I mean, we were targeting kind of a different population, but it's a very interesting question and interesting area, because although it's only 5%, it still is 5%, and there really isn't, much targeted research for those patients.
And they're the patients that end up with a very long length of stay.
Yeah, and quite costly. So it's a very interesting question.
Very. Okay. Thanks for answering all those questions. I know we have a few more, but I think it's time to turn it over to John as we come to a close. So thank you very much. John?
Thank you. So thank you to both Susan and Kristen for that very interesting and informative webinar. And as with all scoping reviews, it certainly highlights further areas for further work, either both for more research into the area, looking at increasing the quality indicators, or actually their adoption. So I look forward to further work on this, and thank you again for presenting. Just to finish off, I just want to highlight some of our upcoming events at TVN, which I hope that you'll be able to, the attendees on the line, to be able to participate in. The first one is our annual conference, which is coming in September 27th to 29th. It's in Toronto. It's the 3rd annual conference, and registration is currently open. I think it will be very informative. It's looks at presenting state-of-the-art lectures on care of the frail elderly, or those that are in late life, and also is presenting some of the results of our research studies that we have commissioned at TVN, which have been completed. In addition, we have just launched a 1-year fellowship program, which is tiered to the level of training, and this is certainly would be of interest to anybody looking to do research on improving care of the frail elderly, or learn best practices for care of the frail elderly. So please be on the lookout for this, and we look forward to your application. It's going to be launched on September 8th, in which we'll have all the details for the application. Finally, at the Canadian Hospice and Palliative Care Conference in Ottawa, we have a session on frailty measurement as a way to increase the adoption of end-of-life care or advanced care planning. So if you are attending the CHPCA, please come to that symposium, or think about attending the CHPCA conference in detail. It's very informative and very useful, especially for people who are interested, who are researchers or clinicians dealing with the frail elderly. Our future TVN webinars, as I said before, these are We do have these monthly, and they're usually the first or second Wednesday of every month. Our next one is Wednesday, September 9th, and that looks at rehabilitation for the frail elderly, models of care and quality indicators, and that's by Laura Giangregorio and Caitlin MacArthur from University of Waterloo. That promises to be very interesting and follows closely to some of the things discussed on this webinar. And on Thursday, September 10th at 12 noon, we have an information webinar looking at the MyTax Accelerate program, and this is looking at leveraging research dollars and training through TVN, through the TVN MyTax Accelerate program. So please tune in for that if you have an interest. I think that this is potential of high value and would be of interest to anybody who is training HQP within their organization. Finally, our webinars, as I said before, are going to be available in the next couple of days, and the website is listed on the slide. All the webinars that we've done since the inception of the webinar program are on our website. They are a rich resource. Please make yourselves, please avail yourselves to this resource. It is quite good. And also for the future, we are in the midst of planning for webinars in 2016. If you have an idea for a webinar that you would like to present either on your research or other topics of interest that you would like us to do, please send us an email. We would gladly look into it, and as I said, and as we fill out 2016 webinar series, your input would be very valuable. So finally, I'd like to thank everybody again, our presenters and yourselves for participating in today's webinar. A very brief survey will pop up on your screen within a few seconds after the webinar is finished. We really value your feedback and specifically on questions questions and opinions on how we can continue to improve the TVN webinar series. So please fill out the survey. We do look at them, and they are of high interest to us and use to us. So thank you again to Susan and Kristen for presenting, and thank you for taking time out of your busy schedules to attend the webinar series. And until the next webinar, we'll bye then.